Stanford Conversations in Menopause and Healthy Aging, the podcast, a trusted science-backed resource in menopause and healthy aging. When it comes to your medical and health education, tune in and submit your questions to world-class leaders in medicine and research. Stay informed, stay empowered, because your health matters.
Hey there, and welcome back to the Stanford Conversations in Menopause and Healthy Aging podcast, the podcast about living well through perimenopause, menopause, and beyond. I'm your host, Dr. Karen Adams, board-certified OBGYN and lifestyle medicine physician and director of the Stanford Program in Menopause and Healthy Aging. My guest today, Dr. Sharon Hung, is an assistant clinical professor of internal medicine and the director of women's health in primary care and population health at Stanford Healthcare. Dr. Hung and I have done all kinds of projects together that involve teaching providers here in the Bay Area and really all around the world how to manage menopause. But today we're shifting gears to teach women who are going through it. She's joining me today for a 3-part series. Together, we will give you the foundations for what you need to know as you navigate your perimenopause and menopause journey. Welcome, Dr. Hung. I'm so happy to have you today.
Thank you, Dr. Adams. I'm happy to be here too. I'm excited to have the opportunity to just pepper you with questions.
Right. Me too. So let's jump right in. Why don't we start with perimenopause?
Okay. I always like starting with definitions before we delve in. Can you walk me through the definitions of premature menopause, early menopause, perimenopause, and menopause itself?
Right, absolutely. So premature menopause is a very specific term, and it means menopause that's happened before the age of 40. And that can happen because of medical conditions, autoimmune conditions, genetics, things like that. It can happen because of medical treatments like cancer treatments, chemotherapy, things like that, or surgeries. So if someone's had their ovaries removed, usually for some type of cancer, that can put someone into premature menopause. But the definition is very specific. It happens before age 40. Early menopause is also very specific, and it's menopause that happens between the ages of 40 and 45. So that's just on the earlier side. Typically, that can be really for all the reasons that I just went through. But it also can be just a family history of people going through it in a little bit of an earlier time frame. The perimenopause are the years that lead up to menopause, which is menopause is literally one day in a person's life. It is the day that it has been 12 months since your previous period. So when you've gone 12 months without a period, that is your day that you are in menopause. And for the rest of your life, you are postmenopausal. On average, menopause happens between age 51 and 52. And perimenopause is the term that we use for all those years leading up to that final menstrual period and then postmenopause.
Thank you for clarifying those terms. And how long does perimenopause typically last?
Well, I have some bad news for people, and that is on average, it's about 7 years. So it is a very long time. It can be from 1 to 10 years, but on average, it's about 7 years. And when you think about the last menstrual period being age 51 to 52, we're talking early 40s that people are starting to experience it typically.
Wow. And I think that's so important for people to know that it can last 7 to 10 years, because some people might feel like, oh, I can just tough this out. Maybe I don't need to talk to my provider or consider treatment options.
Right, exactly. Or the symptoms can start to be kind of subtle, and then they get less subtle as the process goes on. But often people are just like, what is going on? I just don't feel normal. And it takes a little while for for them to click and to think, wow, this could be perimenopause. And it can take a little while for the providers to sort of click and make that connection as well.
Yeah, I do hear women often say things like, I just don't feel myself, as
Right.
their opening line.
I
And
think
so,
that's probably the most common thing, isn't it? Don't they just come in going, I don't know, but something is off?
right, right.
Mhm.
So then, how can we explain what's happening in their bodies and what's happening with the hormones as they're going through perimenopause?
Right, right. Do you have that conversation with your patients? Do you kind of explain what is going on? I always do because I think that helps people wrap their head around it a little bit. Do you do that as well?
Yeah, absolutely. Especially after learning from you over the last couple of years, I've gotten better at explaining that.
Right. It's just so helpful, I think, to understand that when you're having a period every month, what that tells us, what that tells me, and what that tells you, and what that tells the patient is that the brain is sending a signal to the ovary every month. The brain is talking to the ovary, and the ovary's responding, and it's making hormones. And so your estrogen goes up, comes down, you ovulate, make an egg, your progesterone goes up, comes down, you have a period. The whole thing starts over again every month, and it's very predictable, very consistent. Estrogen up, down, progesterone up, down, period. Over. For years, it does that. It's very predictable. What happens in perimenopause is the brain is still sending that signal to the ovary every month the way it always does, but the ovary is aging. And as the ovary ages, it just responds less and less reliably, less consistently. I mean, it basically sits there and just goes, yeah, no, I'm not. I'm not doing anything. Nope. And then all of a sudden it wakes up and it makes this big surge of hormones. And then it kind of goes back to sitting there and then it wakes up and it's completely random. So you never know. And that's what makes perimenopause so hard is you never know when you're going to have a period. You never know when you're going to have a hormone surge. You never know when you're going to go 3 or 4 months without a period and you start having all kinds of symptoms. And then lo and behold, your periods start up again. So it's completely unpredictable. And people think they are losing their minds because they never know. They get up every single day, not knowing how they're going to feel. And, at least with PMS, the week before your period, you're going to feel crummy or you're going to have your symptoms, whatever. This is like PMS all the time, except it's completely unpredictable. And some days you feel good. So that's what makes it really hard. That's also why blood levels don't help us in the perimenopause, because I could draw your blood every week for 6 weeks and it's going to be up, it's going to be down, it's going to be all over the place. So it doesn't tell me anything that your symptoms and your bleeding pattern isn't already telling me.
Yeah, I love the way you explain what's going on the ovarian level. And yes, that's such a great point to emphasize because that's also a very common question I have patients ask is, oh, can you just check my hormones so I understand what's going on? And it's important to understand that that's really not helpful during this time period.
Right. It's actually so frustrating for people because they're like, I just need my hormones checked. And, if you're dealing with something like hypothyroidism, low thyroid, we check people's hormones all the time and we adjust according to what we're seeing with those hormone levels. But we can't really treat perimenopause that way. And in postmenopause, the hormones are just completely stable all the time. And there's no point in checking them because I know already what they're going to be, because you're in postmenopause. So I wish that we had some sort of a fine tuning that we could do with the hormone levels, but that really doesn't exist for perimenopause and menopause.
Yeah, and as you mentioned, the bleeding can be really unpredictable during this time. And also, there's a lot of variability between different women. So I think instead of asking you what bleeding patterns are normal during perimenopause, it might be better to ask you what types of bleeding are not normal in
Mhm.
perimenopause.
Right, exactly. Because I have seen people come in and they have just been bleeding so badly and really having a lot of difficulty with it, and they've just thought it was perimenopause. So I do think it's really important to say that if it's really heavy, you're filling up a pad or a tampon every hour or two, and that's going on for 6 or 8 hours, that is not normal. If you're bleeding for 14 days at a time, if you're just bleeding forever, on average, periods last 3 to 5 days. If you're bleeding 10 days, 12 days, 14 days, that's not normal. If you're passing big clots, that's not usually normal. So skipping periods is normal. Maybe having shorter periods is pretty normal, but those heavy, clotty, crampy, gushy periods, that's not perimenopause. That can be things like fibroids or a polyp or a thing called adenomyosis. They can be other causes, usually not hormonal. So if you're having just horrible, long, heavy, terrible periods, you should definitely check in with your provider about that.
Yeah, those are all great things to keep in mind. And also wanted to emphasize you mentioning that it is normal to have more frequent, lighter periods at times, since I think women often expect their periods to slowly space out, and that's not
Mhm.
always the case.
Right. Sometimes you'll ovulate and then ovulate again relatively quickly, and you get these funny little shorter cycles. So, 80% of people get hot flushes and night sweats, so that's like one of the most common symptoms in perimenopause, but 100% of people get bleeding changes, so the bleeding changes will always happen. And when you're starting to notice that your cycles are getting really dysregulated, that's probably a time to check in.
And you mentioned hot flashes and night sweats. When do those tend to start in perimenopause?
Hot flushes are pretty unmistakable. If people say, "Wow, I'm just kind of feeling warm all the time," that isn't really what a hot flush is. A hot flush feels like someone has turned on a heat lamp and it is just coming at you from inside. People often have visible changes like red face, sweating through their hair, just, looking like they're having some sort of a, I don't know, panic attack or something. And it can feel that way because it can feel like heart racing and heat and uncomfortableness. And so that usually when people are having those, they realize that they're having them and they know that that's what that is. But they can start in the early 40s, and people even in their 45 to 47, 48, about 80% of people are hot flushing by that time. And daytime is hot flushes. Night sweats are sort of the nighttime equivalent of that. But again, we're up to 80% of us in our mid to late 40s. So often right before, periods start to change. And so that should be a real red flag. If people are starting to notice that, they should check in with their providers.
Yeah, so the heat lamp is a very interesting visualization. But I'm really curious, since this is really the main focus of your medical practice, what are other ways you've heard women describe their hot flashes?
Mm-hmm. Yeah, they are. Some people describe them as feeling like something is coming from their hips up through the top of their head, that they kind of feel it coming up through their body. Other people describe it as feeling like a heat lamp has been turned on inside and they're sort of, it's sort of radiating outward. But they really are a true physiologic event, and the best studies looking at hot flush treatments not only do symptom reports, but they do what's called skin plethysmography, where they're measuring the temperature on the skin because your skin temperature goes up. It is physiologic. Your temperature goes up on your skin, your face gets red, your heart beats more fast, and you can be sweating. So I have a patient who's an attorney, and she is like, I just cannot get through a meeting with a client without sweating through my blouse, and it is driving me crazy. So these are incredibly distressing, and it's embarrassing if you're trying to be at work or, your kids are making fun of you because you're sweating.
Yeah, those descriptions sound very uncomfortable, and I can't wait for when we talk about treatment options. But I have one more question about bleeding. So, if someone's had like a hysterectomy, or they have an IUD, or they're on continuous birth control, and so they're not having periods, how do we figure out where they are in the process?
Mm-hmm. That's such a great question, and there's even some discussion among the menopause experts in the country that maybe we need a new definition because so many women have experienced either hysterectomy or they're on some kind of a medical treatment that suppresses their periods. And so then that definition of no period for a year doesn't apply. So then in that situation, we sometimes do blood levels, even though it's not ideal. It can give us a little bit, maybe, of a sense of where someone is. The other thing that we mostly do is we just go by symptoms because we know that hot flushes and night sweats occur in 80% of people. And of course, we look for other causes, maybe thyroid, maybe, malaria or other kinds of things that can cause people to be sweating. But, having a high index of suspicion when someone's in their 40s and experiencing those symptoms. And again, recognizing and having that awareness that it can happen even early in the early 40s so that we're not just dismissing people and saying, oh no, you're too young for this to be happening to you.
Right, right. Yeah. And I want to emphasize that since I do hear that women are often dismissed that their cognitive or mood changes or their insomnia are not related to perimenopause if their periods are regular. And that's just not true.
Right, exactly. And on average, people go to 4 or 5 providers looking for someone to help them explain what's going on and to address it. So it is really, it's just so important that people like you and I are out here kind of beating the drum and raising awareness. And I'm so glad there's just so much more awareness about it now. So I think, and providers are becoming more aware too. And we're doing our part for that, for sure.
Yeah, and speaking of awareness, I think there's, often not enough knowledge about ethnic and racial differences in presentation. Are there differences in ways that people of different races or ethnicities experience the menopause transition?
Absolutely. A really important point because we know most of this through a study called SWAN, the study of women's health across the nation, where they actually enrolled women by race and ethnicity. So they were able to track their experience of perimenopause and menopause and correlate that with their race or ethnicity. And so based on that study, what we know is Black women have more severe hot flushes for longer periods of time than any of the other groups that were studied. So almost 50%, almost half of Black women are going to experience severe hot flushes for, on average, 10 years. So a long time. Hispanic women are a close second, so it's a little more than a third of Hispanic women are going to be having severe hot flushes for almost as long, on average about 9 years. Caucasians are somewhere kind of in the middle. About 25% of them have severe hot flushes on average. That's about 5 years. And then our Chinese and Japanese friends, neighbors, colleagues are a little bit less, only about 20% are experiencing severe hot flushes, and those last only, a little less than 5 years. So we don't really know why that is, why those experiences are so variable among the different races and ethnicities that were studied. That's really great area for future research, like what exactly is really driving that different experience across the different races and ethnicities.
Right, that's really fascinating.
Mm-hmm.
And women are always asking me when I think they're going to go through menopause. Are there other factors that can make women go through it earlier or later?
Mm-hmm. There really are. Early menopause is associated with a long list of particular characteristics. Interestingly, being a twin puts you more at risk for an early menopause, which I think is really interesting. We don't really know why that is. If it's a family history, if you have a family history of earlier menopause, definitely that you're more at risk for that as well. Many of us never had the talk with our mothers about menopause the way we have our talk about about puberty, but if you can find out from your mom, that can give you a little bit of an inkling of what time you might go through it. Also, if you started your periods really early, so if you went through menarche at age 8 or 9 or 10 really early, then potentially you would have an earlier menopause as well. If you never have children, if you've never been pregnant, never had a baby, that puts you at risk for a little bit earlier menopause. Overall, poorer health status. So if you've got a lot of medical conditions or a lot of chronic things that you're dealing with, you tend to tip into earlier menopause as well. Smoking makes people go into menopause earlier. Some cancers do, like we talked about, some of the cancer treatments, but some cancers in and of themselves can make people go into menopause a bit early. Autoimmune conditions like Fragile X or Sjogren's syndrome or lupus, things like that can cause earlier menopause. Interestingly, what we call ACEs, or adverse childhood events, also can put people into earlier menopause. It's just a correlation. We don't really know what the causation of that is, but we see that association. Also, current life stress, in general, lower levels of education or employment, living in rural areas. And the other thing is working night shifts. Isn't that funny? If you work the night shift, like most of your career, you will be more likely to go into menopause early. Going into menopause later is associated with good health habits like exercising, eating well.
Yeah, that's all really interesting because a lot of risk factors that you mentioned we can't control, and so knowing that there's something that we can take action on is really helpful information. And you mentioned earlier the SWAN study, and there's a statistic from the SWAN study as well that only 7% of midlife women are meeting the recommendations for exercise goals. So I think we really can't stress that enough, that people need to be exercising both cardio and strength on a regular basis for a variety of reasons.
When I get interviewed, and I'm sure you say the same thing, when I get interviewed for different magazines or different media articles, people always want to know, what can you do to prepare to go have a more smooth transition through perimenopause and menopause? And that is always the number one thing I say is start exercising now. Exercise is so essential for healthy aging.
Absolutely. So I think most patients and providers know to expect hot flashes as part of the menopausal transition, but what are some other common symptoms that can occur during the perimenopause transition?
Right, exactly. So everybody starts skipping periods. That's a universal symptom. 80% of people get hot flushes and night sweats, either one or the other or both. But there are a whole gamut of other symptoms that often people don't necessarily connect. So sleep disturbance is very common. It's about 50 to 60% of people experience some kind of early morning awakening with difficulty going back to sleep, that kind of thing. About 60 to 70% of people experience a thing called perimenopausal mood instability, which is mostly anxiety and sort of irritability, but can also be low mood or depression. Then there's brain fog and cognitive changes, word finding difficulty, memory isn't quite what it used to be. That's really common. Joint pain is really common. There's a thing called musculoskeletal syndrome of menopause. And again, even if you've never had any kind of joint pain or aches, about half of us will start to experience that in perimenopause. Sometimes urinary leakage, either leaking when you cough or sneeze or laugh, or on the way to the bathroom and you're like, ooh, I might not make it. That kind of urgency is a common symptom. And then, of course, the genitourinary syndrome of menopause, vaginal dryness, burning, pain with intercourse, feeling like you have a UTI all the time, and every time you pee in a cup, it's normal. And so you have that kind of feeling of frequency and urgency without a UTI, or recurrent UTIs can also be something that we see in perimenopause and menopause. So those are kind of the big categories. And then there are a whole bunch of other ones that vary from person to person. Weight gain is really common. Dry skin, dry hair, dry eyes is common. People can get palpitations. People can get ringing in their ears, burning on the soles of their feet. So there are a lot of things that are a little bit more atypical that often hormone therapy resolves. And that's really how we know. If the symptoms are not related to perimenopause, they don't go away when we treat with hormones. So if someone has joint pain, for example, and I put them on hormones, they should resolve if it's related to perimenopause. And if they don't, if they still continue to have those symptoms, then we need to look for other causes.
Absolutely. So thank you so much for having this conversation today, and I can't wait to talk more.
I am so delighted to be able to chat with you about it. I always learn something when I talk with you as well, and I really want to thank you for being with us today.
Thank you.
And so please join us for the second part of our series on the menopause journey, where Dr. Hung and I will come up again, and we will be talking about treatments for both perimenopause and menopause, because yes, it's uncomfortable, but you do not have to suffer. And there are effective treatments that work very quickly. So I'm looking forward to part 2. And thanks again so much, Dr. Hung.
If you've enjoyed this episode of Stanford Conversations in Menopause and Healthy Aging, please take a moment to follow or subscribe to our podcast on your favorite platform, and consider leaving us a rating or review. It's a simple, zero-cost way to support our work and help others discover the show. You can also stay connected with us on Instagram, YouTube, and other social media at Stanford Menopause. For additional resources, event notifications, and other updates, be sure to visit our website, menopause.stanford.edu, where you can also sign up for our program newsletter. Thank you for joining us, and most importantly, thank you for your interest in advancing the conversation around menopause and healthy aging.